Assalamu alaikum. Let me welcome you on behalf of Ahsan Academy to a presentation on the heart. This is the third part of the presentation on the heart. Let us fix the objective of this part of presentation. Here in this part, I will discuss the vascular and nerve supply of the heart, the lymphatic drainage of the heart, radiological anatomy of the heart, living anatomy of the heart, that is the surface anatomy of the heart, and at every stage I will try to correlate the anatomy with the clinical aspects. Heart is supplied by two coronary arteries, right and left. These are the first branch of the ascending aorta, and this is named as coronary artery because it looks like the total artery when made a cast. Then it looks like the crown of the king. Because of this shape of the arterial pattern looks like the crown, that's why it is known as coronary artery. The coronary artery arises from the aortic sinuses. What is actually the aortic sinuses? If we see the pulmonary trunk valves and the aortic valves, these are arranged in three layers. The first front layer, right and left anterior of the pulmonary trunk. Behind there are one valve of the pulmonary tract, one valve of the aorta. So this middle layer is known as posterior for pulmonary trunk and anterior for aortic uh, sinuses, and behind that left and right posterior aortic sinuses are there. This is actually depending on the embryological distribution. You see that this was a common tube and this is divided by septum, and because of the rotation this is the final position of the sinuses and uh, valves of that area. So uh, anterior aortic sinus present in the ascending aorta, and two posterior aortic sinuses are there. This is the left and right. The right coronary artery arises from the anterior aortic sinus that is shown in the figure by the arrow, and after arising from the aortic sinus, this passes fast anteriorly and slightly to the right. You can see in the figure below between two structures. This is on the right side, it is the right auricle, and on the left side this is the origin of the pulmonary trunk. So it passes between these two structures and enters into the atrioventricular groove. This follows the atrioventricular grooves. This is the atrioventricular groove, the groove between right atrium and the right ventricle sternocostal surface. In the atrioventricular groove, it descends downward and reaches up to the acute border of the heart. This is the right coronary artery descending downward, and this one is the acute border of the heart. So the artery hooks round the acute border, continues in the atrioventricular groove up to the origin of posterior interventricular groove. So at this junction between the atrioventricular groove and the posterior interventricular groove is known as cardiac cracks. So this artery continues up to the cardiac cracks. It gives up there the one branch. It is the artery to the posterior interventricular groove. The right coronary artery continues in the uh, atrioventricular groove, crosses the cardiac cracks, and little to the left of the cardiac cracks it anastomoses with the branch of the left coronary artery. Here this anastomosis is very insufficient in nature. And see, this is circumflex band, and with this circumflex band this right coronary artery makes an anastomosis. Let us show the branches. This one is the right coronary artery labeled with the arrow. The first branch is the conus artery. This is supplying the SA node. This is the anterior atrial branches. They are more than one in number, and this is supplying the right atrial wall. This is opposite direction. The arteries, it is spread over the anterior wall of the ventricle. This is known as, these arteries are known as anterior ventricular arteries. So anterior atrial arteries are more than one. Similarly, anterior ventricular arteries are more than one. This is the right marginal artery. This is one large artery. Follow the acute border of the heart, and it ends short of the apex of the heart. This is the artery arising in the diaphragmatic surface, as the right coronary artery hooks round, continues in the inferior surface. This gives ventricular branch to the posterior wall, and these arteries are known as posterior ventricular artery. And then it gives the final branch, that is the posterior interventricular artery, and continues into the atrioventricular groove, and finally anastomosis with the circumflex artery of the left coronary artery. Right coronary artery has this distribution, means supply area. It completely supplies the right atrial walls, shown in the figure on the right figure, shaded. And this, the second figure from the right, is the section through the ventricle, and green is showing the area of supply of the right coronary artery. And similarly, green stains will be shown on the other hearts. Most of the right ventricle is supplied by the right coronary artery. It is not supplying the area close to the anterior interventricular groove. This is arrow is showing on the sections. This is the green area is the supply area. The posterior part of the left ventricle, that is the diaphragmatic surface close to the posterior interventricular groove, is also supplied by the right coronary artery. The interventricular septum, usually the posterior 1/3 is supplied by the right coronary artery through posterior interventricular branch. The SA node is usually supplied by the right coronary artery and also AV node. Left coronary artery is wider, but it is shorter, much shorter than the right coronary artery. It arises from another aortic sinus, that is the posterior and on the left side. Let me show with the arrow. This is the left posterior aortic sinus, and this is the origin of the left coronary artery. It's having a very short course, passes between the left auricle and the pulmonary trunk. You can see this small course. This is the auricle and this one is the pulmonary trunk. So it passes between these two. This remains hidden under these two, between these two structure, left auricle and pulmonary trunk. And when it is coming out in the atrioventricular groove, it divides into its two terminal branches. You can see the anterior terminal branch is anterior interventricular artery, and the circumflex artery that continues in the left part of the atrioventricular groove. This one is the anterior interventricular artery, and the other one is circumflex. Let us see the branches of the left coronary arteries. Left coronary artery is very short, and this short uh, course may have some branches. One is anterior atrial rami. Anterior atrial rami arises from mostly from the circumflex, but one or two branches may arise from here. And another SA nodal artery, rarely SA node is supplied by the left coronary artery. Then this artery arises from the trunk of the left coronary arteries. Two terminal branches are the main branch. It is the circumflex, that is actually continuation, and the major branch is the anterior interventricular artery. The distribution of the left coronary artery, naturally it supplies the left atrial wall, shaded red, and in the most of the area of the left ventricle, you see it is shown in the section by the red dotted arrow. The right ventricle is supplied, this is the sternocostal surface close to the anterior interventricular groove. Then this is the stained area is showing the area of left coronary artery distribution, and it is supplying the anterior two-third of the septum, shown by the white arrow in the section photo. AV bundle is supplied by the left coronary artery, and rarely it is supplying the SA node. SA node is usually supplied by the right coronary artery, and this is distributed directly to the SA node area. But in some cases, this may be supplied by SA node may be supplied by the independent artery arising from the anterior aortic sinus by the site of origin of right coronary artery, and rarely it is supplied by the artery from left coronary artery directly. You can see the figure. This is showing the wall of the heart. So the inner wall is endocardium, then is the thick myocardium, and after that this is epicardium. The blood vessels, they mainly larger arteries, the coronary arteries and the major branches are usually sub-epicardial in origin, means it remains outer part, and it divides into a smaller branch and proceed towards the endometrium, but it becomes very minute arteries when it reaches the endometrium. So it is supplying the outer part to inward and gradually decreases the flow towards the inner side. On the contrary, we know that the blood is in the lumen. So blood contains oxygenated blood, that is nutrition and oxygen, that diffuses and meet the demand of the inner part. The dominancy of the coronary circulation is determined by the origin of the posterior interventricular branch that supplies that is present in the posterior interventricular groove. So the green stained heart in the figure, you can see that right coronary artery is giving the branch, the posterior interventricular branch. So this is the right dominant heart. On the contrary, the red stained one, the posterior interventricular branch arising from the circumflex branch of the left coronary artery. So this heart is left dominant. So the posterior interventricular branch actually supplies the part of the septum, one third, and as well as the part of the ventricle close to the uh, interventricular groove. In most cases, we get the right dominant arteries, and then this is having some clinical significance that we will discuss later. So clinical significance in case of left dominance, let us see the figure. This is the normal distribution of the coronary artery in right dominance case. So in right dominance case, still the left coronary artery supply demand is relatively more. Now, if it is left dominant, the black dotted arrow is indicating, this area will also be supplied by the left coronary arterial branches. So if you see, the dot lines is indicating on the right side, the small area is supplied by the right coronary artery, and on the left side, the most of the heart is supplied by the left coronary artery. So the left coronary artery faces a major myocardial demand of nutrition, including oxygen. So vascular disease is common when these persons have the left dominant coronary circulation, and usually this type of persons life expectancy is low. This diagram is showing the two artery is supplying the two areas, and this is schematic diagram, and these two are connected by one anastomotic channel. Now suppose one artery is blocked, then this anastomotic channel will be effective and will meet the demand, and the tissue will continue life. But on the left side, let us see another figure, they are not connected by anastomosis. So if one is blocked, then the area supplied by this will die. This is end artery. Now this may be having anastomosis, but this anastomosis is not sufficient to meet the demand of that area. This is known as functional end artery. Coronary circulation, there is anastomosis, but it is not sufficient to maintain the viability of the tissue if one is occluded. That's why coronary circulation is called functional end artery. This is the area you see, one artery is blocked, there is anastomosis between anterior and posterior interventricular artery in the inferior surface, but this anastomosis is not enough to maintain the demand. So if anterior interventricular artery is blocked, the area will be necrosed, means die. And now this circulation, we know that the from outer to inward the circulation is coming, and the outer part is more getting more nutrition than the deeper part, means close to the lumen, which is also supplied getting nutrition directly from the bar. But if this artery is occluded, then the first sufferer is the part close to the lumen, means deeper part close to the endocardium. So necrosis or death starts from endocardium to epicardium. Let us discuss the venous drainage. The main vein of the heart is the coronary sinus that empties directly into the right atrium. There are some small veins that directly opens into the right atrium too. Coronary sinus, you can see the figure is this is present in the posterior part of the atrioventricular groove, and it is formed by the two union of the two veins. Great cardiac vein, it is leveled, and this is the left marginal vein. So the left marginal vein and the great cardiac vein unites to form the coronary sinus on the left side, on the posterior part of the atrioventricular groove. It runs right to the right side, and this is a very wide venous channel that drains the most of the blood to the right atrium. It lies in the posterior part of the atrioventricular groove, and it runs from the left side to the right. The coronary sinus receives some tributaries. These are the great, small, and middle cardiac veins. Let me label that. This is great cardiac vein. This one is the middle cardiac vein in the posterior interventricular groove, and this small cardiac vein follows the atrioventricular groove. So the great cardiac vein with the marginal vein actually forms the coronary sinus. Then it receives other branches, like this is in the inferior surface there are some posterior veins of the left ventricle. This directly opens in the coronary sinus. Also another vein This vein is oblique vein of the left atrium, opens just after the origin of the coronary sinus. This coronary sinus directly opens into the right atrium. The opening of the coronary sinus lies between the opening of the inferior vena cava. It is labeled, this is the inferior vena cava, and between also right atrioventricular opening, it is labeled. So the coronary sinus is, the opening is between these two structures, so inferior vena cava opening and the atrioventricular valve. Other small veins are labeled here. This you can see the anterocardiac vein. This is running in the wall of the sternocostal surface, the right ventricular part. They are uh, multiple in number, more than one in number. This is the right marginal vein. This follows the acute margin of the heart and finally drains into the right atrium directly. Other some small cardiac veins, they are very small and difficult to identify and open into the all cardiac cavities, any cavities they can open. Lymphatic drainage. This lymph starts from the plexus of the lymphatic vessels. This plexus lies just under the epicardium, under the endocardium, and inside the myocardium. So at all level we'll get the capillaries. They unite together to form larger trunk that run into the anterior interventricular groove, and this trunk again fuse together to form the larger trunk that is present in the atrioventricular groove. This atrioventricular trunk in the anteroventricular groove directly opens into the lymph nodes or directly into the thoracic duct. The lymph nodes are tracheobronchial group of lymph nodes. The nerve supply to the heart is distributed from the cardiac plexus, which is situated near the arch of the aorta. It's a mixed type of plexus, combination of parasympathetic and sympathetic. The fibers from this cardiac plexus is distributed to the heart with the coronary vessels, and it is mainly controls the conductive tissues of the heart, and that part mainly includes the SA node. The sympathetic supply arises from the upper 5 or 6 thoracic segments, and the postganglionic fibers arises from the cervical and superior thoracic ganglia of the sympathetic trunk. The sympathetic stimulation causes the increase in the heart rate, impulse conduction, and force of contraction. The coronary blood flow is increased to support the increased demand of the myocardium. The sensory impulse follow the sympathetic pathway, and it is insensitive to stimulations like touch, cut, cold, and heat. This is the pain stimulation initiates through the ischemia, means decrease supply of oxygen, and this is imbalance of the oxygen demand and supply. Then accumulation, and other cause is accumulation of metabolic products because of the failure of drainage of these after products of metabolism of nutrient substance. The nature of cardiac pain is simple discomfort to a very severe form, and it's a feeling of pressure over the chest or squeezing of the chest case is the feeling, and usual side is the center of the chest towards the left side, and other sides radiation sides are shown with the red staining in the body. Parasympathetic supply is through the vagus nerve. The second order neuron of this parasympathetic pathway is from the intrinsic ganglions that is present in the atrial wall or interarterial septum and distributed along the coronary. Parasympathetic supply, if stimulated, slows the heart rate, reduces the force of contraction, and constricts the coronary arteries. In this way, it saves the energy between the period of increased demand. Let us discuss the radiological anatomy, means how the heart is reflected in the X-ray film. You can see the right side, the X-ray film is shown the normal heart shadow. Heart produces whitish shadow because of it's a muscular organ containing no air and contains blood. And on the other side, the lung shadow, as it contains the air, is relatively blacker. Now let us see the diagrammatic representation of the cardiac shadow with the labeling. The lower labeling is showing the right atrium, right ventricle, cardiac apex, then the left ventricle, left atrium, pulmonary trunk, aortic arch, and on the left side superior vena cava, and then you can see the aorta, and again you can see the right atrium. So cardiac left border means here we are observing on the right side. So this left border of the cardiac shadow from above is the aortic arch, then is the pulmonary trunk, then is the left atrium and left ventricle. Let us fix it on the heart shadow and take it above. You can see the structures. So left border of the heart in the X-ray frame from below upward is the left ventricle, pulmonary trunk, and aortic arch. So these are known as, from above downward, the aortic arch is the aortic knob, then is the pulmonary conus, then atrial shadow, and ventricular. Both are left. So apex can be also identified. On the right border, on the contrary, is the superior vena cava above, then it is formed by the right atrium mostly. Let us go for the summary. You can see this X-ray film and the cardiac shadow, and easily we can say the left border of the heart is formed by the aortic knob, then pulmonary conus, left atrium, and left ventricle. On the other side, it is the superior vena cava and the right atrium mostly forming the right border of the cardiac shadow. Living anatomy of the heart. We can draw the borders of the heart on the anterothoracic wall. The apex is situated at the left fifth intercostal space, just internal to the mid-clavicular line. This is the mid-clavicular line, and the point on the apex is there. You see, in some cases, we express that position of the apex, mentioning the distance of the apex from the midline, like 9 centimeter from the midline. But it's not correct to mention the measurement from the midline. It's better to mention that this is internal to the mid-clavicular line, because the dimension of the body may vary. Some person may be very thin, though that person is adult, and some persons are being adult having almost double measurement. So in centimeter, if we express, that may be a mistake. So we should say in this form. In this form, we can draw, measure the point on the apex, then another point over the third costal cartilage close to the sternum on the right side. This is the sixth costal cartilage close to the sternum, on the right side and a point on the second costal cartilage close to the uh, sternal end of the costal cartilage. Now, if we add this point, keeping the left border convex to the left and right border convex to the right, and inferior border convex inferiorly and superior border convex, slight convex upwards, then we will get the shadow of the heart over the front of the thoracic wall. In this way, we can draw certain important points like aortic valve to listen the sound of the aortic flow of the blood through the aortic valve. We can place the stethoscope closer to the sternum on the right side of the intercostal space. In this way, we can draw the position of different valves or bays or other structures on the anterothoracic wall. Thanks for remaining with the presentation.